From the heart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Weill Cornell Medicine on Medscape Cardiology and the heart.org. I'm continuing my series of conversations with leaders in the field of cardiovascular medicine who are working on what I'll call interesting projects and making contributions in the science and policy space. This show is going to be a little different in that we have three guests joining us here today. And the three guests have recently written two papers in JACC, the Journal of the American College of Cardiology. One, an original research paper that's dealing with the issue of private equity's acquisition of outpatient cardiology practices. And the second is an editorial that really tries to get at why this is happening. Is it a problem? Is it a solution to a problem? What is it? And so fortunately, I have all three guests to join us today to really think about this important issue that has implications for clinical care. It has implications for reimbursement. It has implication for physician wellness, clinician wellness, and it has issues regarding public policy and how we should be thinking about the practice of medicine in this country. So I'm fortunate to be joined by the authors of those two papers. Joining me here today on Medscape Cardiology is Dr. Victoria Bartlett. Dr. Bartlett is an internal medicine resident at the Brigham and Women's Hospital in Boston. She's also a research fellow in the Smith Center at the Beth Israel Lahey Medical Center in Boston. Dr. Bartlett, thank you for joining us. Next up is the senior author on paper written by Dr. Bartlett, Dr. Rishi Wadhwani. Rishi is an associate professor of medicine at Harvard Medical School, and he is the associate director of the Smith Center at Beth Israel Lahey. Rishi, thanks for joining us.
Thanks for having us, Bob.
And then finally is the editorialist on the original research article is Dr. Ed Fry. Dr. Fry is the national service line leader for cardiovascular medicine for Ascension Health. Dr. Fry is also a recent past president of the American College of Cardiology. Ed, thanks for joining us today.
Great to be here. Thanks.
I was intrigued by the papers that came out, and then it caused me to do a deeper dive into some of the earlier works that had come out that you have referenced about this growing topic, if you will, of private equity making its way into medical practice. And maybe, Rishi, I'll start with you. What is the business of private equity?
Yeah, thanks, Bob. Private equity firms basically used pooled investments from multiple sources. It can be individual and institutional investors, pension funds, endowments, and they use those funds to invest in private companies that have the potential to return a profit. And so these private equity firms typically try to add value to the company. And in the case that we're going to be talking about today, outpatient cardiology practices, within 3 to 7 years, and then subsequently tend to sell their stake in that entity or practice at a higher price than what they purchased it at. And the goal really is to turn a profit for institutional investors over a shorter time horizon.
And maybe this is the broad question, Rishi, is that how do they do that? Like, I can understand you buy a factory and you want to make the factory a little more efficient, and you think that perhaps by combining some technologies, et cetera, that you might have in other factories, you can drive more value out of the one you just invested in a short period of time. What's the general business sense of how they're going to do that in the cardiology practice? Is it all about making us more efficient?
Yeah, I think operational efficiency is sort of the overarching theme here. And, one could argue that perhaps private equity firms have the expertise to bring that kind of organizational know-how and operational efficiency to medicine. There's evidence that the way that private equity firms maximize their margin, the way they do that is maybe through mechanisms that aren't necessarily good for patient care, like reducing nursing staffing when private equity comes in and acquires hospitals, acquiring practices in the same location so that they have greater negotiating power at the payer table to have higher prices for the services they deliver. There's a lot of discussion about whether this organizational efficiency, these sort of changes that private equity firms tend to implement, whether they're good or bad for patient care and also for clinicians.
So great summary. Ed, why does this happen in medicine? What did we do in medicine that made us ripe for investment by private equity? You know, when you and I started out years ago, I don't think we ever would have thought that this was in the future.
Well, I think a couple of things. I think number one, as we know, medicine represents about 20% of our economy. So there's huge amounts of money that are, involved in these considerations. Players in this space, if they can have access to even a small fraction of that amount of money, it's a lot of money and a lot of incentive for them. I think, broadly from medicine in general, and then maybe more specifically from cardiology, number one, we've seen a shift away from private practice into employed practice. And when people made those decisions, over the last 10, 15 years, there were certainly positives and risks that they took. And I think for some along the way, they realized there was some, perhaps they gave up more than they thought in terms of control and running their own business and opportunity to sort of shape that themselves and be rewarded for that as they were in private practice. I think in cardiology, more specifically, we've seen very much this shift to the outpatient space, moving diagnostics and even therapeutics into like ambulatory surgical centers and outpatient-based labs as another potential source of revenue for these private equity companies. But I think, as I wrote about, there are certainly a lot of pressures and frustrations that the day-to-day clinician feel that, maybe this move to PE is more of a symptom of those concerns, and that this is sort of an opportunity to take the bull by the horns. Again, in cardiology, as you well know, we've sort of evolved from a predominantly hospital-based acute care specialty into one of chronic disease, of diagnosis, chronic disease management, and longitudinal care, punctuated by diagnostics and therapeutics, which are, again, I think, attractive to private equity firms as potential sources for revenue.
Ed, why cardiology? What's happened over the years that have led to that appearance, if you will, of private equity in cardiovascular medicine?
So some of the earlier ones, as you know, dermatology, ophthalmology, gastroenterology in particular. And, interestingly, those tend to be specialties that have less chronic disease management and more sort of based on procedures and things like that. I think within cardiology, obviously the big driver is that our population is aging. 11,000 people turn 65 every year, become eligible for Medicare. And with that, we see a rise in disease prevalence, and then the rise in risk factors, obviously, with obesity and diabetes. So there are more people who are going to have, an illness that requires evaluation, diagnostics, and procedures. And because of that, is a very rich, target-rich environment for private equity.
Now let's dive into what you did, Victoria. What got you interested in the question, and give us some background on what was the literature that you were trying to build upon when you asked your series of questions?
There's been a lot of interest, as you all know, in private equity and acquisitions in healthcare. A lot of it has been, the existing literature has been around hospital acquisitions, what happens there. There's some literature, as you've mentioned, in outpatient practices, in certain specialties where PE has existed a little bit longer than it has in cardiology. They've been asking really similar questions to what we have been asking about cardiology, which is like, where are these practices being acquired, and what happens when it does. And kind of an overview is many of those studies have found increased costs to payers, to patients. And many have also found evidence of decreased quality. The evidence there is kind of honestly more difficult to figure out, but there's been evidence of decreased nursing ratios in nursing homes. There's been evidence of kind of changing the staffing mix in clinics to have more advanced practice providers than physicians. There's been some evidence in hospitals that maybe quality doesn't change too much, but I think the deeper kind of layer under that is that these PE-acquired hospitals may also be selecting certain patients that are kind of less sick, that are not going to affect their metrics as much. So that's kind of the environment that we had been reading about and starting to look into, are we seeing that in cardiology too?
Share with the audience, what did you do? You took what I would call a descriptive approach to trying to understand what the current state of the landscape is in cardiovascular medicine. As Ed's already pointed out, a lot of the earlier data does not concern cardiology practices. So my read of your paper is that you were trying to at least lay the groundwork for us to understand as a community what's going on out there. Is that a fair interpretation?
Yeah, absolutely. And I think it's more challenging. Even that initial question of just what's happening is more challenging than it seems like it might be to answer, partly because these private equity, they're private transactions. They don't have to publicly report anything. And so there's a lot of manual work to gather this data. There's a lot of interest in it, but it's a lot of manual work. That was our first question of, what are these transactions? When are they happening? Where are they happening? And, what are the clinics that PE firms are interested in? What are the community characteristics of those clinics? What could that tell us about what's going on?
Tell the audience broadly what you found. What are those clinics, and how often does this happen? And then we'll move into the sort of what does this mean kind of questions. But give the audience just the basic description of what's in the paper.
We looked at acquisitions between 2013 and 2023. In that 10-year span, we found 41 acquisitions of outpatient cardiology practices, which corresponded to 342 acquisitions of clinics. And the vast majority of these, pretty much 95%, occurred between 2021 and 2023. And we calculated that about 3% of cardiology clinics in the US are owned by private equity. Looking at, where do these acquisitions happen? The states with the highest number of acquisitions were Florida, Texas, and Arizona, and particularly the urban areas in those states, Jacksonville, Houston, Dallas. And interestingly, that mirrors what we've seen before in anesthesia and dermatology, and the places that PE firms are targeting in those specialties. And then our last question around community characteristics, we looked at several. The one that had a statistically significant association with PE acquisition was we found that private equity firms were less likely to acquire clinics in the highest poverty communities. Other than that, we also looked at, within these communities, the proportion of adults over 65, proportion of racial and ethnic minorities, educational attainment, rurality, and didn't find any significant associations between PE acquisition and those characteristics.
Thank you, Victoria. Rishi, do you want to interpret why private equity was targeting these certain areas that Victoria and you found in your analyses?
That was a great summary by Victoria. I think private equity goes where they can actually acquire practices. So we know these are those states in particular, states that have more independent practices than, say, a Massachusetts does. The target population is available in those states. And I think building on what Ed's said earlier, why all of a sudden, because Victoria just pointed out that the vast majority of these acquisitions have happened between 2020 and 2023. And you see the surge, and I expect that surge to continue over the next several years. And the question is why? And it's many of the reasons that Ed laid out. Cardiovascular disease is common. We know with the rise in cardiometabolic risk factors that we're seeing at a population level that the cardiovascular disease is only going to become more common. Cardiac procedures are very well reimbursed. And so there's likely a lot of appeal in entering a specialty with a highly profitable service line. And then, over the last decade, federal policymakers very intentionally have created incentives to shift the delivery of cardiac procedures to non-hospital settings. And we see that with the rise of ambulatory surgical centers. And more of these types of more cardiac procedures are being reimbursed in these types of settings. And I think that private equity firms may see this as an opportunity to maximize profits. We shouldn't ignore the fact that when Victoria created this beautiful map in our study that showed how concentrated these acquisitions are. They really concentrated in specific markets. And I think that parallels what we're seeing sort of with health systems more broadly, this sort of consolidation and concentration. The ultimate goal, I think, being that these different stakeholders, it's not just private equity, have more market power so that when they go to insurers, they can demand higher prices for procedures and different services.
It's hard to look at the dates of 2021 or 2020 to 2023 and not think that, is there a COVID effect? And I'm sure you've been asked that, Victoria. Do you think there's a COVID effect, or is it just true and unrelated?
I mean, I think COVID definitely put a lot of financial pressure on providers, and particularly small independent practices, would have felt that the most. And I certainly think that contributes. It may be a piece of the picture, may not be all the picture, but I certainly think that is part of the picture. Yeah.
Yeah, that's what I would have guessed as well. The financial pressures that we were all under, but in particular the small independent practice that didn't have the big, health system behind them to backstop things. Ed, as a former leader of the ACC, and the ACC very much cares at the local level by state, are you hearing preferentially from the governors, for example, of these states that this is an issue, and then other states you're not hearing at all?
Well, certainly this activity is concentrated in the states that Victoria and Rishi described for the reasons that they outlined. I would say, this is still a very small number, and probably will remain relatively small if we consider that 85% of cardiologists are employed, and the bar to exit an employment arrangement to enter into a private equity situation is pretty darn high. There's a lot of costs associated with that. So it may have sort of have a finite cap to it, and that may be part of what buffers the some of the response. I would just go back and again to address other reasons why this is happening, and particularly because of the aging population of the cardiovascular patients. We've also seen the rise of the penetration of Medicare Advantage, which is a type of value-based, if you consider it as a type of value-based care, there is actually incentives built into Medicare Advantage to manage costs and to do those various things. So there is certainly a reward incentive there. I'm not wearing my hat as a representative of the ACC nor Ascension, and I will probably be a consumer of these services before I'm ever a participant in these services. So I would say that private equity in some respects is really acting as a disruptor also in this entire process. If one of the positive outcomes from this is for a reevaluation of the role of clinicians in the overall delivery of care for health systems and academic medical centers, I think that could be a positive. So, always trying to trying to look at the bright side of things here too.
Yeah, this is great because I have two broad areas that I want to end with. One is the opportunities, and then the second is what else is needed. And to your last comment, Ed, maybe I'll ask you, Rishi or Victoria, any insights into clinician wellness, how people feel when their practice has been bought by private equity? Is there any data out there?
Not that I know of, and Victoria, please feel free to correct me. I will say that we have a study under review right now that looks, it's not this doesn't answer your question directly, Bob, but that looks at how private equity acquisitions of US hospitals affect patient care experience. And what we found is that using sort of a rigorous quasi-experimental study design, comparing private equity acquired hospitals to neighboring control hospitals, that private equity acquisition leads to a pretty marked decrease in patient care experience and satisfaction. So capturing another dimension of quality that mortality and readmissions don't necessarily reflect. Doesn't answer that question directly, but I think that's an important area for future research, understanding the effects on the clinician experience as well as, most importantly, the patient experience.
Yeah, nicely said. It seems like a good time to think about real mixed methods of qualitative, focus groups, et cetera, coupled with the more quantitative methods. Victoria, as you thought about it, I suspect you talked to people in practices, any insight, whether it's observational or rigorous data on the clinician experience?
Not that I have seen. I think it's a really good point. I think, and I imagine it's probably mixed because, as we've been saying, there's a lot of financial pressure on practices, small independent practices, and it can become overwhelming to try to run them. And I think PE firms offer a very attractive value proposition, or can, and I imagine that people might have mixed feelings about it, but I think it's a great point that should be highlighted. Yeah.
Ed, we've heard Rishi and Victoria talk a bit about the research opportunities that we need to look into. Let me ask you again, taking your, I'll call it cardiovascular leadership hat, not any one specific organization, but your leadership hat. What are the policy things that we should be thinking about as a country in this space?
I think there's an opportunity to sort of combine these conversations around research, collecting more data, and the advocacy issues related to that. I think, one of the things that perhaps differentiates cardiology in this space from other specialties or subspecialties, surgical subspecialties, is the plethora of data, our registry tools that we already have well established. We have good benchmarks from a professional society standpoint. We have an obligation to make sure that the care that is provided in whatever environment meets the standards and is measurable and is reportable and provides a level of consumerism to patients and payers to be able to look at that. So I think from a professional organization standpoint, I think we have an obligation to advocate for the use of well-validated registry tools to track the data, to have real objective data to be able to demonstrate the types of outcomes. And actually, it's interesting. There's an ACC-AHA policy document from 2020 on the professionalism and ethics of cardiology. And within it, it calls for the obligation of the profession to make sure that in alternative sites of care that we are achieving at least as good a result, if not better result, in those alternative sites. So I think we have to be true to that.
I was actually a co-author on that paper on professionalism and talking about some of the research and education issues within the academic medical centers. And I think you're spot on. And I love the comment about the importance of longstanding registries, whether maintained by the ACC, the Heart Association, STS, where we can get insights into the quality issues. clearly going to need some work done on the patient experience, the clinician experience. So I also take the positive from you, Ed, that this may be a disruptor that could lend itself to some positive change in other areas that need some change. Well, this has been a fantastic conversation on the appearance, if you will, of private equity in cardiovascular medicine. Some of the observations made by colleagues at the Smith Center at the Beth Israel Lahey. Great commentary by Ed Fry on whether this is Symptom solution and what we might be thinking about from a broader societal perspective. I want to thank my three guests today, Victoria, Ed, and Rishi, for joining us here on Medscape Cardiology and theheart.org. And I want to thank the listeners for spending time with us. And we look forward to hearing whether this was something that piqued your interest and you want to hear more about. So again, from theheart.org and Medscape Cardiology, thanks for joining us today.